Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with my good friend Bill. How you doing, Bill?
I'm doing great, Dennis. How are you?
I'm doing well. One, happy holidays. Two, would you, since this is your first time on this podcast, would you mind doing a real quick intro?
Sure. Bill Vashis. I'm a PA right now. I've been a PA for just over 20 years. Prior to that, I was a Special Forces medic and a weapons guy and an engineer. And prior to that, I was a commo guy in the Rangers. So I consider myself a pretty cross-trained SF guy.
Right. One of the reasons why I asked you specifically on this is I think you really kind of pioneered ultrasound at least in the soft community. I guess one, why did you push so hard to have ultrasound in our tax sets and in our kind of lexicon?
Well, I was initially an opponent to the idea because at the time we only had one ultrasound per battalion, and it was for the vet at group level. So it was very difficult to justify having, 35 to 45 medics in a battalion and, one device. So, unless we were going to start doing cage matches to see who got the device, we needed to increase the number of devices we had. And to do that, you had to justify purchasing them by being able to train guys. Now, SF guys are some of the smartest guys out there in the military. I mean, they're a certain subset. They're filtered out to make sure that, we get what we get. And you can teach them anything. And so by solving the logistics problem of making sure that everyone had a machine to use, or at least have, a reasonable expectation that they would get access to a device, then why would we even start training them in the first place? It's not like we don't have 1,001 other jobs as medics on the team,
Yeah, absolutely.
So I just happened to be in a situation where I had a really motivated doc that asked the question, and based on my initial pushback, we started working through some of the problems of, if we're going to do this, let's do it right. Let's figure out how to make sure that when we get trained, we can actually use a device. And then we presented that idea high up the command and gave them options, and they decided to incorporate, the training program that we had developed into the schoolhouse and into the groups. And that was my job for 4 years before I moved on after that. So I think we're full of good ideas, and this good idea needed a lot more solutions before it was truly a good idea.
Right.
And it's a tool. Ultrasound, in fact, is a tool. So how can I become a better provider? There's a spectrum from you getting injured, me coming up to you and trying to treat you, and then getting you to the point where you're better. That whole spectrum, some of it I can solve at point of injury. Some of it I need to do something into prolonged field care. And then, more than likely, most often, I'm going to have to get you to somebody else for them to do the definitive care and all the follow-on and aftercare. All of those things belong. All of those are on a spectrum. And what can I do? What tools do I have in my bag, or I have access in my team room that I can further you as far as possible along that spectrum, so that when I send you to this location, I have a higher reasonable certainty that I'm sending you to the right place. Or
right.
Any treatment that I do while I have you in front of me is as productive as I possibly can, or at least I'm not doing a bunch of experimental things to try and figure out, oh, this was right, this was wrong. So if I have a tool that can help me figure that out before I do something that's definitive and I can't reverse, like sticking a needle in a chest or putting a tube in a chest, then why would I not use it?
Right, I understand. But I guess my question is, I understand you had like one vet or one ultrasound at the vet, but what problem were you trying to fix? MOI plus one, that works everywhere, and it's really never wrong. So I guess why are we wanting to add, or why did you want to add ultrasound to the mix?
Well, it wasn't my idea. It was a question that was posed to me by Drew Morgan, who was the battalion doc for us in 1st Battalion 3rd Group. So it was his crazy idea, and I don't know who he got that from beforehand, or was it just his? But it was a good question, and it required a lot of thought and planning to figure out, is it truly a good idea, or is it just one more thing that's going to be, a good idea that adds to our duties and responsibilities but doesn't really benefit us.
Right.
We thought that we had a nice iterative process to where we got a few extra machines and we trained folks to use them, and then that showed that we could do it, and that justified getting more machines and doing it. So, and it was just a case of if it is going to be a good idea, then let's work it through. So it. I don't like where I'm going with this.
Okay, but are we fixing a problem?
Well, we didn't know we needed an iPhone until it was put in front of us, right?
True.
So we can't always just say this is a problem. And that's a good place to start. Like, this is a problem. How do I solve this problem? But this was being done in emergency rooms, everywhere. Well, not everywhere, but a good portion of places had this as point of injury evaluation. It's definitely in the ER. So how do we extend that to the pre-hospital environment? At the time, those machines were pretty good size. So I don't think it was ever a ruck device that we would carry in the ruck, although we did test it in Afghanistan. Had a modified M9 bag that one of the medics actually designed, and it was brilliant. It was padded. It had just one M9 bag with a Sonosite M Turbo that was rigged so you could just pull the cord out of the bottom and plug it in, and you had all the probes stored in the area that was padded. It was very durable, and it made a lot of sense for what we were doing. We could just take a D-link, put it through the top handle, and hang it up in the vehicle so it didn't get crushed under the ammo and water and food and feet, that's going through the vehicle. So that was brilliant. But I think bringing it pre-hospital, where we have to make a lot of decisions that kind of choose a path for the patient, it makes sense to know as much as possible before you start off on that path.
Oh yeah, absolutely. So just statistically, I want to say each intervention that penetrates through the skin in a hospital increases your likelihood of an infection by 3%. So that be IVs, that could be crikes, chest tubes, whatever. So needlessly, and that's in a hospital, not in like a ditch or wherever in a wadi or wherever else you find yourself. So that's, being able to, I think, accurately diagnose a chest injury, more so than, I think, or like even worse, like what harm is it going to do by actually doing this intervention, a finger thoracotomy, and what harm could it possibly do to my trauma patient by just doing it?
Well, I can tell you that I've made the mistake both ways. I've put a chest tube in somebody that I realized after I put it in that they didn't need it. And there was another patient where we didn't put a chest tube in for at least a good 15 minutes while we were trying to figure out, looking at a portable chest x-ray to determine, is there a reason to put a chest tube in? And in both times, once we did it, it was pretty evident that we should have either not done the chest tube at all because there wasn't a pneumothorax. There was plenty of superficial penetration of the skin, but it didn't actually go into the thorax and the chest cavity, so the lungs weren't compromised. And in the other case, there was, a good 400 cc's, 400 to 500 cc's of blood that was in the chest that you just really couldn't appreciate on the portable chest x-ray just because of the nature of a portable chest x-ray. So, in both cases, if we had put an ultrasound on the patient's chest, we would have known instantly one way or the other.
Right.
So any tool that would help you from not making one mistake and preventing another is a tool that I want in my bag, or at least I want somewhere close.
Yeah. So, just kind of caveat on top of that, how hard is it to actually, to diagnose a pneumothorax? What I have at my disposal, other than ultrasound, I have hands on his chest, which are calibrated, of course,
Yours too,
and a
right?
stethoscope, right? And maybe a pulse ox. So, I mean, with those things, basic things, like how hard is it to actually diagnose a pneumothorax or maybe even a hemo?
Right. Well, you have the IAPP, right? Inspect, auscultate, palpate, and percuss. And so am I going to be able to visually see based on mechanism of injury or obvious penetrations to the box? Yeah, that's one thing. If I listen, am I going to be able to tell the difference between the two? I've already acknowledged my inadequacies in being able to detect, one side that had pneumothorax and the other side that didn't. And then, palpate, I can look and feel if I have, potential rib fractures or subcutaneous emphysema or any other indications that there's compromise of the thorax. And then, good God, if I can figure out percussing to look for tympany, I should still have the anatomy book out on how to do physical exams and turn to the right page. Because if I'm at that level, I really shouldn't be doing what I'm doing. So if I use the tool, what you're looking for is lung sliding.
Right.
And whether you pull out a high frequency linear transducer to determine if there's lung sliding of the parietal and visceral pleura between the rib space, or you use the abdominal setting on a low frequency curvilinear or a phased array transducer, and you just set the depth to somewhere between 4 and 6 centimeters, you can detect whether there's lung sliding present.
Okay.
You can. And then if that doesn't work, almost all of the ultrasounds that are out there now have M-mode or motion, and you can put a line on there, and with the line you can actually see a tracing alongside the bottom of your screen that will show you that from the area from the surface of the skin to the pleural lining is no movement, and then below the pleural lining you're going to see what is commonly referred to as the seashore sign, or you're going to be able to see that with 100% certainty.
With ultrasound, I think it's kind of black and white. It's either there or it's not. With just IAPP, just in my experience, which I am not saying that I'm even a good medic, but IAPP, I have been definitely burnt before. Like you mentioned, a patient with a hemilobectomy, and he called you out?
Pneumonectomy. Yeah, so the whole lung was removed from cancer, I presume.
But I've definitely been burnt by people that, they already knew they had, whatever trauma to it, but just IAPP are like, yeah, everything's good.
Yeah.
So I think, even though with T-Tri-C, you have to kind of almost go with your gut and think of what is the worst case scenario. Let me get ahead of it. When you can, I think you'd be, I don't know what the right word is, complicit, or, you are definitely at fault if you have access to an ultrasound and you refuse to use it instead of whatever gestalt you have. I don't know.
I think the word you're looking for was cavalier. You could be a little cavalier and just do it. But so I have a great imagination.
Yeah.
And so if I understand the mechanism of injury, I have a very good idea of what could be wrong. I don't know. I've said this in classes before. I could take and stab you over near the liver. Right, I could stab you on the spleen side, and I have a reasonable suspicion of what the injuries could be on the inside, on the other side of the skin, but I truly don't know. Was it that freakish 1 in a million where it just missed everything vital and didn't hit any major vessels? But I don't know. Same thing with a gunshot. Gunshots, those things take left and right turns all the time, and so you really don't know. But you have a good imagination of what the potential injuries are based on the mechanism of injury. So if I'm going to be cavalier or aggressive, and I'm just going to do everything that I can do to make sure that you make it through the TC3 phase to get the PFC, then then I may have a good outcome and I may not. There's a good percentage of patients that I could do everything wrong and they're going to survive despite my best efforts.
Right.
And the other side of it, I could do everything right with a full team of trained people and we have every diagnostic tool imagined and they still die. So you have those, but that 15 to 20% of patients that are in the middle that whether they live or die really depends on the care that we provide. You want that to be the best care possible.
Right.
So I think specifically for ultrasound, if I'm going to use that tool and I'm going to spend extra time, it's so I don't do something that I don't have to do
Right.
on a patient. If the patient is stable enough or their vital signs are good enough that I have the time to do the diagnostic exam to make sure that if I do this test, it's truly necessary, then I'm not going to say negligent, but I'm kind of a dick if I don't.
Right.
So why would I not want to get good at a diagnostic tool or with a tool to be a better provider?
Right. So I guess kind of going with that, I mean, what kind of tools do you want? I mean, some devices are very ruggedized. They have chips and it's, just a wand. Some are, you have, multiple different wands. I mean, do I look for things that have the best resolution? Do you look at things that have the best durability? Like, just in your professional opinion, austere experience, what would you look for?
First of all, I try to figure out where am I most likely to use it,
Mm-hmm.
right? And if I get a device that's small enough that I could use it, not during initial injury, but if I have a team and I could be that extra person that runs between multiple patients and provides additional information that will help correctly prioritize them in the triage, then that would be one scenario. But if I know that I'm the only medic on this team or for this mission, and I'm going to be the only medic for the whole time I'm out there, then I'm not likely to use it right at point of injury because I'm going to be too busy doing the initial TC3. Mm-hmm. And there really is no part of ultrasound in TC3 at this point. There's some devices that are small enough, but once again, you still have to follow March and all of that. So I'm going to be well into my secondary exam, and I'm going to get to the point where I can document all the stuff that I've done in the TC3 phase then before I'm going to pull this tool out.
Right.
Because if the patient is presenting clinically that they need something, then I'm going to do it. I'm going to be that cavalier medic, and I'm going to do it because I don't have time to figure out if I don't have to do it.
Okay.
And that's all based on how that patient is presenting. I mean, the more aggressive their symptoms are, the more aggressive I have to be in response. Now,
right.
The idea for me to be slow to be smooth, and by smooth, I'm going to be fast, that still applies, right? I still need to take a breath and make sure that I'm doing the right thing and I'm not just amping up my pulse in response of theirs.
Right.
But having said that, if I'm at the point where I have calmed down and I was able to not do a procedure because the patient was clinically kind of in that iffy stage of, do I need to do it? Do I not? And I can watch them to see is more on my gestalt and my experience. And how many times have I put in that situation? Can I get away with not doing a procedure right now? Because I've seen patients like that. And I know that, based on my history of it, 1/3 of those patients are bad, and I'm totally making up numbers.
Yeah.
But I'm going to make that gut call based on my experience and how the patient's acting.
Right.
But then when I get to the point where I can take a break and pull it out, it needs to be at least handy, whether it's in the vehicle in a bag or it's in my, team clinic or, wherever I'm going to be.
Okay.
So first off, I decide where am I likely to use it? And then that is going to go into the decision process of what device do I get or what do I need? And I don't see why, if we approach every other item that we have in the tax set with the rough truck house planning paradigm, well then I would do the same thing with ultrasound. If I have a device small enough to carry with me with point of injury, but it sacrifices clarity of image or durability, or it's more durable but it doesn't do as much, then Do I have a device for me that I carry with me? And do I have a different device that's in my team clinic that never leaves the clinic?
So, I mean, most of it, what we've been talking about so far is just the lung slide, right?
Right. That's just one trick.
That's just one trick, right? Obviously you have the entire EFAST exam. And then of course there are other mnemonics, but for kind of the trauma aspect of it, EFAST. Mm-hmm. What other kind of things can you do with ultrasound?
Well, if you're doing skin, soft tissue, musculoskeletal stuff, you can detect a fracture. You can detect a foreign body, whether it's glass, wood, plastic, stone, metal, doesn't matter. You can find that in under the skin somewhere. You can do intraocular pressure to detect elevated intracranial pressure. I mean, there's been some studies to say that that's a simple process to do. I'm pretty facile with ultrasound, and it really depends on the patient. Mm-hmm. So if the patient's looking around all the time, you're not going to see the optic nerve sheath because that patient's eyes are going everywhere. So, but that's not necessarily part of the training, is to figure out how to get your patient to look in one direction long enough that you can find the optic nerve sheath to measure it. Right. That's one thing. I can use it to start a line. I can use it to do a peripheral block, peripheral nerve block, I should say. I can look at kidneys. If I got somebody with polyp pain, I can scan their kidneys to look for hydronephrosis to see that a stone is obstructing the ureter. I can look down in the bladder to see if there's bladder jets, that the ureters are not obstructed. All of that can go into trying to figure out what really is going on with my patient. Right. Then the patient always gets to throw you a curveball because they can have more than one thing going on. True. Without sending the memo. Like, right. Oh, by the way, I've had this festering infection that was going on before I got shot. Yeah. So, what's going on?
I mean, at least in my uneducated opinion, really it's the sky's the limit. How smart are you at basic physiology, and what can you imagine that you can see?
Well, think about it. Every other test, every other diagnostic test that you do in medicine should be for a reason. Uh-huh. You do your good history and you do a physical exam, right? And then you go, here's my differential, my list of differential diagnosis, and then I'm going to do a test to figure out what I can take off my list and what moves up higher on the list. That's all it is. And so if I have a question, I wonder if there's a foreign body in there. I wonder if there's a fracture. I wonder if he has free fluid in the peritoneum. I wonder if he's got a pneumothorax or a hemothorax. I wonder, what the heart is doing, because I got this funny looking beat, or funny looking EKG. What is the heart actually doing? I'm going to do some diagnostic study, whether it's conventional radiology or CT or MR, if I'm in a hospital, but I'm also going to do ultrasound in a hospital. A lot of ERs will pre-scan something to get an idea, start the treatment, and then order, something that's more definitive or comprehensive, either a more comprehensive ultrasound study or sending them for other imaging. But it's something that I can do point of care that answers a question that I've formed based on what I've done, but the questions I've asked the patient and the physical exam I performed. Right? Right. And so sometimes, is it an abscess or is it just cellulitis? That dramatically changes how you treat that patient.
Right. So I'm getting ready for deployment. So what should I be doing as far as getting myself up to speed on ultrasound? Do I need to go to a course? Is this something that I can just get a book? Is this something I need to put more effort into?
Well, I understand that all the SOCMs and 18 Deltas are graduating with some experience with ultrasound. So you at least have an idea of what your comfort level and exposure has been to this point. When they do hospital rotations, they play with them, and there's no shortage of people that will tell you how to do this, better. A lot of times those are misguided and well-meaning, but not actually helpful. But there are a lot of people out there that know how to use ultrasound, and they're very good at it. And so you have to make that judgment whenever they're, it's kind of similar to golf instructors. You're on the range and they'll tell you, hey, I can tell you how to drive it a little bit farther or fix that, cure that slice of yours. There's a lot of people that teach ultrasound the same way. They're offering some ideas, but in the end, you just got to shake your head, say thank you, and go off and figure something else out.
Right.
But more often than not, you're going to have some people that are really good at it, and they'll give you a little tip or a little trick that you can take away.
Okay.
You know, you're not going to remember everything that they say, because otherwise you'd be good at it from the first time you play with it. But I think just having it out and using it. When I first learned, I was learning the same time as the medics in my battalion. Mm-hmm. And so my motivation was their expectation was that they could ask me a question about it and I should be able to answer it. And so my motivation was to be able to not say, to be in a position to not say, I don't know too many times. Right. Because you keep asking somebody something and they keep answering, I don't know, you're going to stop asking them. And so that was my motivation to learn. So what is your motivation to learn? Is it so you can treat your patients better, so you can do the right thing for your teammates? You know, mm-hmm. Whatever your motivation is, you got to dig down and figure that out. Because
right. How do I recognize somebody in the hospital that actually knows what they're doing?
Find that ER doc that has one in his pocket.
Okay.
Because if they're going to spend the money to have one personally, right, then chances are it's something that they're either really motivated to learn, and they may not know it now, but they're well on their way to learning, or they're just really good at it and they've decided to have an ultrasound because it is a really good tool for them to use. And wherever they're working, for some reason, they don't have enough of them. Mm-hmm. Right? Cool. That's probably the easiest way. Find somebody that's got one in their pocket, or they at least have it at their station and they take it in all the time to their patients.
That's true. Right? That's true.
Yeah, that's probably the first flag, to kind of say, hey, this person might know what they're doing. Okay. If you're doing rotations and you see a sonographer, an actual sonographer, somebody that's school trained and goes in and does the comprehensive studies that are ordered in the hospital, they are good. They're going to know a lot of tips and tricks on how to scan and get a readable image on a patient that maybe isn't designed to be scanned very well. Right. Right. They're going to know. They definitely know more than one way to get an image off a patient that doesn't seem like they want to give you a good image. Okay. Or they'll help show you, like, hey, when you see this and when you see this, you're just not going to be able to see, you're just not going to be able to get an image, and you just have to get to the point where, okay, that's okay. You've at least taken a look with the ultrasound to see if you can determine one way or the other. But at some point, you may just not be able to get an image from that person. And so you need to know when to stop trying, because it's not worth the return on the effort. Right. Right. And that's why they have, that's why you can say, I have an indeterminate fast. I wasn't able to fully visualize the left upper quadrant. I looked everywhere else on the E-fast and I didn't see anything. Right. So you're just saying, I've looked, I didn't see anything. I can't say it's negative, but I didn't see anything to call it positive. So it's indeterminate. Right.
So, with that being said, what is like the common mistakes that you've seen, medics doing that screws up their image and they're not able to make that determination?
I have a slide that basically says the 5 P's to getting a better image. The other working title is how to make your image not suck. Right. Definitely use a lot of gel. You can run out of gel, especially if you're trying to detect a pneumothorax and you're going, all the way up or all the way down the lung. And as you're sliding, you're running out of gel. And so once you run out of gel, air is the enemy of ultrasound. So once you have no gel between the transducer and the body, then your image goes to crap. So first off, have enough gel. Probably the most common thing that people mess up is they don't understand you have to be perpendicular to whatever you're looking at, because all the ultrasounds, they generates a signal and it sends it into the body. It hits something in the body and then it comes back to the ultrasound. So every ultrasound you get out there is just a glorified stopwatch. It sends a signal out, starts the clock, takes time how long it goes to hit something and comes back, and it stops the stopwatch. Then it does some mental gymnastics, some math, and it paints a dot, on a screen. And that's how it does that anywhere from 1 or 2 to 20 million times a second. So sometimes, you have to just figure out how to interpret those dots. Right. And since we've all seen anatomy books and we've looked at CTs and MRIs, they're comparable, but ultrasound is different enough that you still have to understand how to orient what you're looking at on the screen. What is the near field? What is far field? What is, what side are you looking? What side is the probe indicator? Every ultrasound, every ultrasound has a probe indicator. And then you have to figure out what that is on the device. Sometimes it's a dot, sometimes it's a ridge, sometimes it's a, it's a line. Every one of them, they have different ways. So you have to figure out what that is, and then that corresponds with whatever dot probe indicator on your screen. And so everything under the dot on the probe is under the dot on the screen. Once you figure that out, people that play video games are really good at this. They have good visual spatial orientation. But if you suck at video games, then you might need a little extra training with ultrasound. So that's usually they're looking at a really oblique angle to something in the body, and that diminishes the return of the signal back to the ultrasound, so you have a really shitty image. Okay. Making sure you have enough pressure. If you're looking through the rib cage, no amount of pressure is going to get it closer. But if you're looking at the aorta or something along those lines, you got to push down enough to dispel some of the gas to the side so you can get by around that, because air is the enemy of ultrasound.
Right.
If you're looking at the eye, you don't want any pressure, right? So, and then if you have an artifact, which I would say that if you're really good at interpreting what the artifacts are, then you should be significantly better in interpreting the image that you see on your screen. Okay, so artifacts are things that confuse the ultrasound device, but it does consistently. So if I see an artifact, that tells me, if I'm looking at the lung, and I see lung sliding, and I see a little comet tail, which is a little light kind of shooting down from that lung sliding, that's a comet tail. Well, that only happens when both of those, the visceral and the parietal pleura, are touching and moving back and forth. Right. It's a somewhat a surface, not going to say defect, but it's a surface space change from the visceral pleura to the parietal pleura, and that space causes the signal to kind of bounce back and forth, and you get this little comet tail that shoots down. Well, that can only happen when the lung's intact. If the lung drops away as in a pneumothorax, you don't see lung sliding and you don't see comet tails. Mm-hmm. So by seeing the artifact of a comet tail, that tells me that those two surfaces have to be touching. Right? So if you get really good at recognizing all the artifacts, then it becomes easier to recognize when you have a certain condition in the body. Right. It's just associating those two and becoming comfortable with them. If I'm looking for free fluid, sharp, dark edges, follows the contour of the anatomy, and it's not surrounded by a wall that's supposed to be there, that's free fluid. If it meets those criteria, then it's free fluid. Right. So, but part of that is just having it explained in a way that fits and matches what the 18 delta knows. So I think that probably helped me the most, coming from an SF medic background to learning this. I know what the deltas, I've been through the same training as a delta, so I understand what they should know. And so we can take all the fluff that you get from a hospital lecture and put it into just the facts of what we need to know as medics.
Right. Well, thank you, Bill. I really appreciate it.
Yeah, happy to be here.
Cool.
For today's podcast, be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy is waiting there for you.